Good afternoon, everybody. It's a pleasure to welcome you all to this webinar hosted by the SIREN, the Social Interventions Research and Evaluation Network at the University of California, San Francisco, and CHILPI, the Center for Health Law and Policy Innovation at Harvard Law School. I'm Caroline Fichtenberg, a co-director at SIREN, and I'm very happy to see you all joining our webinar on state Medicaid community reinvestment requirements. Next slide. To start us off, I would like to thank the funders that have made this webinar possible, Kaiser Permanente and Robert Wood Johnson Foundation. We're so very grateful for their funding. Next slide. So we're going to be talking today about Medicaid community reinvestment requirements. And before we delve in, we wanted to give you just a brief introduction to what these are. So these are requirements that are part of Medicaid managed care contracts that require the managed care organizations, or MCOs, to reinvest in the communities that they serve. The amount of reinvestment is often based on a percentage of the MCO's profits or something similar to that. And the goal is to invest in strategies other than healthcare delivery to improve community health. Reinvestments are often required to focus on social drivers of health or on other key state goals. Now, this is a growing practice. As of last summer, at least 10 states had implemented or were in the process of implementing community reinvestment requirements in their contracts with Medicare managed care organizations. You can see these states on the map. As these requirements are being implemented, we at SIREN were interested in better understanding how these requirements are being evaluated and how we will know whether they're having the desired impacts. To help explore these questions, we teamed up with Erica Hansen from CHILPI, who will be serving as the moderator for today's discussion. Next slide. Erica is the mastermind behind this webinar, and we're so grateful to her for helping us host this conversation. Next slide. We're also very lucky to have 3 state leaders joining us for the conversation today. Dana Flannery from New Mexico, Elizabeth Hurdle from Michigan, and Emma Sando from Oregon. And finally, we're also joined by Craig Pollack from Johns Hopkins, who will serve as a discussant. Before turning it over to Erica, I want to just go over a few logistical notes. First, the webinar is being recorded, and we will send you a link to the recording as soon as it is available. Usually it's just a few days. We also very much welcome your questions. We have time reserved at the end to have a Q&A with you. But please use the Q&A function and not the chat function to ask your questions. Finally, if you like today's webinar, we hope you are joining us for our February National Research Meeting in San Diego, where we'll be having similarly thought-provoking discussions. And now I will turn it over to Erica.
Thank you so much, Caroline and SIREN. A quick overview of our agenda today. We're going to begin with some presentations from our panelists, sharing some introductory information about their individual state Medicaid community reinvestment initiatives and policies. We're then going to turn to Craig to hear some background on community reinvestment research and evaluation before we launch into a discussion with all of the panelists. Finally, as Caroline mentioned, we should have time at the end for audience Q&A. But as Caroline mentioned, please feel free to pop your questions in the Q&A box throughout the webinar. We don't want you to forget those burning questions. So without further ado, our first panelist is New Mexico's Medicaid Director, Dana Flannery.
Hi there, everyone. My name is Dana Flannery, and I'm the New Mexico Medicaid Director. Thanks so much for having us here today. Very excited to talk about community reinvestment and how we're looking at social determinants of health through the Medicaid space and our many levers that we use in this Medicaid. All right. So just to give some context to New Mexico, we have almost half of our state on Medicaid. So we have obviously a significant amount of poverty in our state. And so really Medicaid does set the tone for healthcare throughout the state. That being said, almost half the state on Medicaid, over 80% of Medicaid delivery is through managed care organizations, or commonly known as MCOs and health plans. And we have 4 in New Mexico as of July. So with July 1st, we launched our brand new updated managed care contract known as Turquoise Care. And really looking at, while we're here talking about community reinvestments today, you can see that in every single main goal within our managed care program, community reinvestments has a spot. And so if you look at goal number 1, that's really on whole person. Community reinvestments allows us to go outside of the generic physical health, behavioral health way that you may think about Medicaid and addressing whole person care, including social drivers of health, or as CMS refers to them lately, health-related social needs. And then in goal number 2, you're going to see payment reform, right? So how are we being very diligent with these dollars being put towards managed care organizations and putting the pressure on them for not only delivery of services, but what the quality looks like and what they're able to address in the member's life. And then on the goal number 3, of course, especially within New Mexico, looking at those groups that have been historically and intentionally disenfranchised and addressing health disparities directly. So within our managed care vision alone, you can see community reinvestment as one of our pillars and our levers that's throughout the whole vision and goals. Okay. So I did show this just to give you some context of community reinvestment is one way for us to have financial accountability for managed care organizations. Depending on where you are in the country, there is added pressure these days on managed care organizations asking us, is this the right way to do it? Was fee for service better? Are these managed care organizations doing the best that they can? And so as we look to evolve our last MCO contract to the new one, I got to be a great part of that, and it was very exciting. We looked at every lever and pressure point that we could do for the managed care. So we required a fee schedule that was a base, a floor. We have performance penalties, so very specific, and you'll hear this kind of weave into community reinvestment, but performance measures that they have to make in order to not hit penalties. And then, of course, I'm sure you're all very familiar with medical loss ratio, really squeezing that all the way at 90%, which my MCOs tell me is really aggressive. And then looking lastly at community reinvestment and really looking at, okay, if you have a profit, what do we do with some of that profit to put back into the community and maybe address the things that you can't in your basic Medicaid framework? And this is how it kind of bleeds back into those performance measures where we're really struggling, even as a state. If everyone puts their best foot forward and we're struggling, how can we get creative outside of the normal space to have an impact on that? Maternal health is one of my favorite topics from this last year where we were able to. So if you're looking at community reinvestment, it says, and this is pulled directly from contract language, the contractor shall demonstrate a commitment to improving the state of New Mexico Medicaid by contributing 5% of its, and this is like that profit margin, right? Up to 3% of after-tax underwriting gain to community reinvestment. So for those of you that don't find managed care finance to be incredibly thrilling, again, they have a certain profit that they can hit, and there's a ceiling to that. And so this is just taking a sliver out of that. That being said, many of us states also do risk-sided corridors, which is double-sided to help them from their losses. In addition to community reinvestment, I didn't want to lose sight of some other creative ways, because I think in this ever-changing environment, we are reliant on these MCOs having a profit. Because if you don't have a profit, you can't trigger community reinvestment. So just before coming here, I just made sure to refresh myself on our MCO finances. And in 2019, 2 of the 3 at the time took a loss. In 2020, 1 of the 3 took a loss. We've had a couple of good years, but they all have assured me that they're all taking losses this year. And so really planning for what are some other things that we can do should community reinvestment not get get triggered. And one of those is value-added services. In New Mexico, we have all of our managed care organizations do value-added services. That's a requirement in the contract. And then before we do open enrollment and really have people decide their plans, we take all of those and compare them. So if you're a pregnant mom, here are all the ones that are for pregnant moms, et cetera, looking at that. And so here's some examples of things that are really difficult to cover in Medicaid, but you could see an individual that has access to Medicaid could definitely benefit from some of these, especially if it's outside of their scope of services based on their eligibility. One fun fact there, we were able to make one of those value-added services reimbursable through a waiver this year for traditional health care, as was Emma. So value-added services is a different example, thinking about what can you do that's not currently covered that may really be impacting a person's life and what that looks like. A lot of the app utilization for members engaging in care differently that way, acupuncture, these are just some examples, but we have a full-scale pamphlet for all members so that they can see a grid of all the plans comparing against each other. Okay. There one more slide for me?
That is your last slide, Director Flannery.
Okay. I think it missed one. So let me just say that in community reinvestment, you know, we've already done some pre-planning this year with our managed care organizations of where they should be driving that. And so again, looking at, as you may know, you assess a lot of the healthcare delivery system through the HEDIS metrics, et cetera, and where they're struggling is where we're going to point them to. Other mentions is that we have rural and frontier areas in New Mexico, which are really, really struggling in the behavioral health realm. And so having them preemptively think and be creative. For us, we have found that it is very valuable when these MCOs get together with their common points of struggle and talk about doing a plan together. So they're all investing in the same places, and then we're able to evaluate what occurred. Our teams pre-approve anything that is going to have community reinvestment monies. And then we measure that on a quarterly basis. Did they do what they were going to say they were going to do? Are we seeing a different in the metric that they thought they would see something in? Are they seeing, and they can self-report to us, other metrics that they're impacting that maybe wasn't the original driver of the community reinvestment, but really looking at what can we do outside the space to be responsive to our community needs. Every single community has its own unique needs, and making sure that you design it as such to have people flourish in navigating Medicaid services as well. Thank you.
Thank you so much, Director Flannery. That was a great overview, and I'm really excited to dive deeper into that and also compare and contrast your program and initiatives with the ones we're about to hear from. So next, we are about to hear from Elizabeth Hertel, the Director of the Michigan Department of Health and Human Services. So Director Hertel, I will kick it off to you.
Thank you so much. And thank you to everybody for joining us today to hear a little bit about what we're doing in Michigan. So I think you can just go right to the next slide. Before I jump into any details on some of our community reinvestment initiatives, I thought it was important to just give you some context of the Medicaid program in Michigan. Between our traditional Medicaid and our Medicaid expansion, which is Healthy Michigan, we have around 2.6 million people in the state who are covered. That's about a quarter of our population here. Our beneficiaries receive their services through one of 9 Medicaid health plans, and we just awarded contracts for those in beginning October 1st of 2024. These plans are vital for us to achieve our mission in improving health, safety, and prosperity. And this rebid was part of our My Healthy Life initiative, which we began in 2022 to strengthen our services through our health plan contracts. Research shows that social and economic factors, as you all know, can drive up to 50% of individual health outcomes. And we know that there is a growing body of evidence that indicates we can improve health and control healthcare costs with investments in these health-related social needs. So our goal and our vision for the My Healthy Life were clear. to bring together the investment, the creativity, and the commitment of the department and our partners, including and especially the health plans, to create a more equitable, coordinated, and person-centered system of care, which we dedicated to ensuring that people have a healthier future. The introduction of the community reinvestment requirement in the Medicaid health plan contracts was an essential part of this effort. So next slide, in July of 2022, we launched a survey to seek some input on opportunities for innovation and improvement in the services and supports that are provided by our Medicaid health plans. We heard back from almost 10,000 residents, and we identified focus areas or our strategic pillars to serve as a foundation for the rebid of those contracts. 85% of the responses came from people who are enrolled in Medicaid or a family member of someone enrolled in Medicaid. And the remaining 15% came from other healthcare partners, either the plans, our providers, behavioral health providers, or health systems. The overwhelming response helped to shape those 5 pillars that guided the rebid: serving the whole person, giving all kids a healthy start, promoting health equity and reducing racial and ethnic disparities, driving innovation and operational excellence, and engaging members, families, and communities. So with this rebid, a suite of new requirements was included in our contracts to help meet the equitable, coordinated, and person-centered system of care that we'd like to see in the state. One of those new requirements under the whole person coordinating health and health-related needs pillar is community investment. So in Michigan, as part of the contracts that began last fall, and I think the next slide has a little bit more on this, Medicaid health plans must reinvest 5% of pre-tax profit into the communities that they are serving. Only Medicaid health plans making a profit in a given contract year will be required, as Dana mentioned. We also require that these investments primarily focus on food and nutrition. We believe that by focusing on one primary domain, we are increasing the likelihood that we are going to see measurable impacts in the communities. Specifically, a minimum of 60% of the community reinvestment dollars are required to fund activities to address food insecurity. Addressing barriers related to food and nutrition is a critical need in the communities across our state, and that need was clear in our survey feedback. This also aligns with our department's broader strategic priorities. We know that there is substantial evidence showing that investing in food and nutrition significantly improves health outcomes and reduces unnecessary healthcare costs. The remaining portion of community reinvestment dollars can support activities that address not only food insecurity, but also housing instability. Another priority for our department and a challenge that I hear often as I travel and talk with people across the state. I'm guessing that your states are probably seeing similar challenges and opportunities. The flexibility that we have here will give health plans and their partners the option to tailor their investments in those areas in ways that make the most sense for their communities. We are still in the very early days of implementing this community reinvestment initiative, but we are optimistic about the results as we continue this partnership between our residents, our health plans, and our community organizations, focusing on food and housing security. The next slide, community reinvestment presents an opportunity to go beyond the traditional and individual Medicaid services designed to improve health outcomes, and it allows for investments into improving the health of communities holistically. An important partner in this work are our community-based organizations. Those are the only entities that will be eligible for community reinvestment funding. Our Medicaid health plans have the opportunity to strengthen their relationships with their community-based organizations. These organizations are trusted local partners who know their communities best and serve as a critical piece of our social services infrastructure. So with the community reinvestment funding, our community-based organizations can ensure that investments are tailored to their communities and their specific needs. Our health plans are also required to consult the communities they serve when deciding what to fund, in line with the parameters that we've set forth in these new agreements. This includes providing updates to community partners about how funds are actually spent. We know health and human services are inextricably linked, which is why we're hopeful that these investments can strengthen and create new connections between our health and human services organizations at the community level with the goal of whole person care. And just to expand on a couple more things that we have done, in addition to that community reinvestment, we're also working to coordinate the healthcare and other social determinants of health. We have several other programs that will coincide with community reinvestments, but our in lieu of services is one that I wanted to highlight as well. As part of our new health plan contracts, we also opted to offer in lieu of services for the first time in Michigan. As you all know, under federal regulations, states have had the flexibility to identify services that they know are medically appropriate, but not eligible for Medicaid reimbursement. Our health plans were encouraged to offer a set of department-approved in lieu of services that address eligible enrollees' nutrition needs. Hopefully, you're sensing a pattern here. We've identified food and nutrition in lieu of services policies that the health plans will be able to offer to address eligible enrollees' health-related social needs. Most of our health plans have indicated that they do want to offer at least one of these services to their enrollees. So the response that we've gotten from them has been positive, though tentative, I will say, because this is new for all of us. So we know community reinvestment cannot be used to pay for in lieu of services directly. It can support those community-based organizations as they develop more capacity to deliver the option. For example, community reinvestment funding could pay for infrastructure, like billing software needed to contract with health plans to deliver in lieu of services. This will make it easier for organizations to contract with those health plans. It's also worth mentioning very quickly our broader social determinant strategy, which we have developed as a roadmap in Michigan. Our health in all policies framework is being implemented through several avenues, which is led by our interagency group outside of just Medicaid. We've established this work group in partnership with the department to bring together other state departments to support better collaboration and alignment of resources. Other programs and initiatives under this strategy include 2 counties in our state that are piloting food delivery service programs, and this is outside of the Medicaid plans. Promoting housing stability through our Good Housing, Good Health program by identifying household needs and connecting them to vital resources and enhancing their housing conditions. So far, we've served over 9,000 households during our implementation period. And one more quick example before I wrap up. We're working on removing transportation barriers for services such as on-demand or ADA accessible routes through a systems information exchange project with our healthcare providers and local transit agencies. These are just some of the examples that we have here in our work to reinvest in Michigan, and we really are looking forward to seeing how these efforts are going to move some of the health outcomes for the residents of our state. So thank you again for this time to share all of this exciting information with you.
Thank you so much, Director Hertel. It's really striking to me how these initiatives are both similar, but also so easily able to be tailored to each state's kind of state priorities and new initiatives, existing initiatives to accomplish those priorities. And I think to elucidate that even further, we will move to the Medicaid Director at the Oregon Health Authority, Emma Sandow. Emma?
Hi there. Thank you so much for having me today. To give folks a little picture of Oregon, not only is it one of the most beautiful states in the entire country, we have 1.4 million individuals enrolled in our Oregon health plan, which is our Medicaid program in the state. And approximately 100,000 of those are in our fee-for-service program, and the remainder are in our managed care program, which is known as the coordinated care organizations within our state. I'm going to walk through 2 of our 3 programs that sort of fit this mold. We've been doing these sorts of programs for quite a while, since 2012 in our state, and have a number of different programs, HRS, HRSN, and SHARE. And I do recognize that HRS and HRSN share a variety of different letters of the acronym, but they are very different programs. So I will walk through them now. So first we have the health-related services, not health-related social needs like HRSN is titled, but health-related services. This is a program that has been in place since 2012 when we established this 1115 waiver, which began providing transforming our Medicaid program into establishing the coordinated care organizations. The CCOs, which was what we call them in the state, receives a integrated global budget for each member, which does provide the flexibility to offer health-related services to improve the health of the overall Medicaid population. These health-related services are non-covered services under our Oregon's Medicaid state plan. So they can be a variety of different types of services, and I'll get into a little bit more detail in the coming slides on some examples of those. But the real goal of the program was in order to ensure that we are looking at the whole person and being flexible where we can be in order to provide a wide variety of services that aren't traditionally covered. And I would also just note that we have 3 acronyms that we're going to kind of be moving here. Flexible services, which I'll get into a little bit more detail, community benefit initiatives, and then the health information technology investments, which are included in the community benefit initiatives as well. Next slide. So some examples of flexible services can include such things as rental assistance, food boxes, air conditioning units, and air filtration systems, which has certainly been an area that we have been focusing on due to the many wildfires in our state in recent years. And other services that help connect people to health in a variety of different ways. And then in terms of the community benefit initiative, examples may include improvements for parks and recreational facilities in neighborhoods that may not have had historic investments, transportation infrastructure, community food access, or needle exchange programs. So you can kind of think of it in terms of flexible services, maybe more specific to an individual, whereas community benefit initiatives, like the name says, are a little bit more focused on the community. Next slide. So as I mentioned, these are for services that are currently not covered under the Medicaid state plan. But CCOs are not required to provide the health-related services that is not a requirement, but all of our CCOs do, because we have in place a variety of financial incentives in order to encourage our CCOs to participate in the HRS. Some examples of those financial incentives do include, similar to the other conversations here, the minimum medical loss ratio, and a performance-based reward calculation to counteract the decrease in premium rates due to the upstream HRS spending. Next slide. So here's a graphic depiction of the increase in total HRS spends over the last several years. We have seen this increase in really across the board in the different categories of HRS spend, but particularly in that community benefit initiative, we've seen a rather significant increase. It's double that of what it was in 2022. Next slide. The average HRS per month in 2023 increased by $3. So we really see that benefit per member really going out into the community through the HRS program. Just a note, we have launched over the course of 2024 a variety of our HRSN, health-related social needs programs, in the realm of devices for air filtration and whatnot, housing and housing supportive services, nutrition, which was actually launched just 14 days ago on January 1st. The eligibility criteria for HRSN is a bit more narrow than health-related social needs. So oftentimes what we're seeing is a person may not be eligible for those HRSN services, but may be eligible for some sort of HRS service if those are available, as we are seeing people come into the door who may be helpful or who may need help, and we are able to provide through a variety of different initiatives for members, because we have this flexibility in place in Oregon. Next slide. So our third program, which has a different acronym, is our SHARE program, which is Supporting Health for All through Reinvestment. Just a next slide. A reminder that we really are looking at, as much as we can, how we can focus on the upstream and community impact of, and that really is the goal of the SHARE initiative, to ensure that we are investing in our communities and improving the overall health of our members in a long scale, and a way in which we'll be able to see the investments take additional outcomes in out years, as the communities are able to respond to healthcare needs of the individuals because of the sustained investment. So the SHARE spending, it is a portion of the profit of the coordinated care organization, or a proportion of the funds available to the coordinated care organizations are required to be spent, and they are focused on 4 domains: economic stability, neighborhood and built environment, education, social and community health. And these we really worked with our community in order to ensure that these were the appropriate needs. So we've been working with a variety of community partners and community boards and organizations to develop these particular areas of focus, as well as our social determinants of health and social determinants of equity partners and partnerships, and really focus on including the community in those definitions that we have developed. Next slide. So here you can see the types of projects that have been focused on those share dollars and share expenditures and activities. Really trying to focus on really building the infrastructure and the sustained ability for community organizations and community groups to thrive and be able to provide long-term services for folks. So things like building property and land, as well as organizational capacity, are areas that have been investments in the CCOs in this space. And for housing is definitely a priority in our part of the country, and we have seen such a great need for housing over the years. And I would say that about half the projects and over half of the dollars have been focused on housing, with 36.8 million invested in housing over the first 3 years of our SHARE program, versus a total of 63 million total reinvested in that time period. Next slide. So for the folks that may have sort of heard a variety of different acronyms and trying to figure out how all of those work together. Our Medicaid members here in blue, a portion are eligible for HRSN services, and then all members that are enrolled in a coordinated care organization can receive some of those flexible services through HRS, and then the broader community really also sees a significant investment in both share and HRS. So we are very excited about the layering that we have here to best meet the needs of people depending on which programs they're eligible for, but all of those programs working together to really meet the needs of the people that we serve. I have a variety of different resources available in the slide deck, which I think will be available online. I do know that I used a lot of acronyms there. We're really proud of our acronyms, and those are going to be available after the fact, but hope that it can be helpful for folks.
Thank you so much, Director Sando, and all of our state presenters and panelists. I'm so impressed with your ability to take these really innovative and expansive programs and distill them into these short 10-minute presentations. We will definitely dive deeper into them, but I think that last Venn diagram did a great job of explaining how all of these programs are really trying to work together to achieve whole person care. Before we dive into a full kind of panelist discussion and Q&A, I'm going to turn to something that I can tell from the Q&A, and I know that this audience is really interested in. Craig Pollock is going to discuss the opportunities and kind of some background for how do we research and evaluate community reinvestment. Craig?
So I want to thank you so much for inviting me to talk today. As you know, when we were discussing this presentation, I said, but wait a second, there really isn't a lot of research that I know about on community reinvestment. This is a new topic. It's a really exciting topic, and we need to have kind of audacity and creativity and rigor in our approach to this, but I don't know of any things that have actually been done that have looked at community reinvestment in particular, so I'm excited. I hope people on this webinar are able to lift up some exciting examples, and I want to offer just a few thoughts that try to frame the discussion. Next slide, please. So we just heard amazing presentations on what's being done in the states, and my hope for research of like, why do it at all? And I think there's lots of different ways that I would love to have the panelists answer, but my thoughts kind of fall into three different buckets. The first is that it potentially could provide a justification for what states are actually doing right now with the money that's being spent. Then I think is also kind of lifted up in some of the questions, how do we have this approach spread if it's successful to other jurisdictions? And then the last kind of goal of research, I think, in this is potentially assisting in maximizing some of the investment's benefit for the communities that are being served. I imagine that there are other ways that research can prove useful in this. Next slide, please. So with that, I want to offer some kind of framing thoughts about this. And the first is that I think it's really important is to think about evaluation at the outset. It's so often easier to think about evaluation when you're like, you know, at the start, when you have like this blank slate and people haven't been allocated resources yet, where it's still kind of in the infancy. And especially in the setting of limited resources, it offers a lot of, you know, different opportunities. I think of like, you know, in Oregon with the health insurance, experiment, and that there's ways that the research can really kind of be baked in at the outset. The second, I think, reason to think about research early on is that building trust takes time, that often these programs are being implemented and, you know, they're still new, they're still got kinks to be worked out. And you want to make sure that you're going in with a sense of trust that can be broached. The third kind of framing thought is around the importance of multiple methods for research. So linking data is one approach to try to get at some of the kind of the effects of what you're seeing, but also understanding that we need to talk to people, we need to use mixed methods, we need to use multi-method approaches to really try to learn from different ways of seeing the world. It was great to hear about some of the community and advisory boards that are existed in some of these programs, and thinking about the ways that those can be used as a sounding board for research, as a way to direct research, as a way to lead some of the research, I think is really important. And then the last thing that I want to say on this slide is around the role of cost savings. So I think we often hear about investments in some of these needs and think, okay, that's going to save health system money. And it's great when that happens, but I think the use cases for that are often pretty small, and that we need to think kind of a broader assessment of value in this setting, where we don't have the same. I always talk about kind of as a primary care provider, that some of what I prescribe to my patients, we don't expect that some of those medicines to actually save money, but we think it helps people live longer, better lives, and I think that should be kind of a guiding star for us as well. Next slide, please. As I was also thinking about this approach to community reinvestment, I thought of this 1970s movie still available on YouTube called Powers of 10, which is a way that I learned, not totally in the 70s, but way that I learned about kind of understanding like powers of 10 and how you can kind of take a different view on things. And it centers on a picnic on the lake in Chicago, and kind of spans outwards and then inwards to try to understand what's happening. And I think with these types of community reinvestment, you can imagine kind of a similar video where you're saying, am I focusing on like the benefits of an individual investment, or am I thinking about it as the sum of investments, some sort of portfolio of investments that the state is making? Am I thinking about it in relationship to the context in which these investments are being delivered, and how am I building evidence across communities? So for me, it's this kind of like, are we kind of being a miniaturist in our approach to research, or are we trying to kind of span out? And I think that there's absolutely value in trying to do both and working with kind of the states and stakeholders to understand kind of what are they most interested in learning, what's the ways that research can benefit their programs. With that, one of the other things that came to mind as we were discussing community reinvestment is taking one of these frameworks that kind of allows us to get a kind of broader perspective. And the framework that I want to talk about is the social return on investment framework. And this is explicitly designed to kind of value the broader social, economic, and environmental benefits from a program. And it uses an impact model or a logic model to try to understand kind of what are the relationships of the inputs of the program and the activities and all of the outputs and outcomes of the programs for the relevant stakeholders. And to do that, it assigns monetary values to the outcomes, and you kind of need to kind of do your best guess based on the literature to assign those values, and then you assign a social return on investment calculation, kind of the present value of those benefits divided by the input costs. Next slide, please. So Emmanuel Drabo, who's one of my colleagues at Hopkins, led us in a social return on investment for a housing program run by Bon Secours in Baltimore. And they'd been investing in housing from the 90s, and they, at the time, had about 800 units of high-quality, affordable housing in 12 different properties in across West Baltimore, where they had on-site service coordinators and properties equipped to support the residents. Next slide, please. And so what we did as part of that is we created this logic model that had kind of the different inputs. You can imagine the housing units and the service coordinators and the funding being part of those inputs, leading to outcomes. And the outcomes were in a bunch of different categories in terms of residents, that benefits to Bon Secours, benefits to the neighborhood in terms of reduction of vacant housing and property values, and benefits to the city government. And we went through and we tried to quantify all of these different benefits and assign both like how many units of these outcomes are we achieving in this investment, and what's the value, the monetary value of these. It's slippery, right? Like I think that that there's sometimes the research is not always great on like trying to quantify it or trying to apply what you've learned in another setting to this setting at Bon Secours, but I think it provides one potential model with which to think about some of the community reinvestment that's being done. Next slide, please. So I think with that, I'm really excited to continue learning from the panelists.
Thank you all so much. And I know we have a ton of audience questions. With that, I think we're just going to have a few follow-up questions. I know I have a ton, but we just have a couple before we open it up to the audience. So Dylan, if you can spotlight all of the panelists. I don't know if you're limited in how many you can spotlight here. But I want to start with the directors, Flannery, Hertel, and Sandeau, whoever wants to start. Can you talk a little bit about what are the desired outcomes of these community reinvestment initiatives. And to circle back to what Craig was just saying, do you currently measure or evaluate any of those outcomes? And do those requirements interact with any of the other programs that have some evaluation requirements, such as if your state has a Medicaid 1115 demonstration, or Michigan's new in lieu of services requirements to achieve some of those goals? Whoever wants to kick it off, feel free.
Happy to. So just a couple of ways to think about this. If we're going to talk about just the narrow angle of community reinvestment, absolutely you need to measure those, right? And so in the case of New Mexico, they submit the plan to the agency for approval. So the agency has the ability to kind of guide that in the first place and say, hey, I really want you all to focus here because this is where you all are struggling and this is what's impacting our members the most, and ultimately how they're navigating the system. And so the measurement typically is those measures we already have in the system. We're going to look to see if those are improving with the community reinvestment. And then sometimes there's ancillary measures too, right? So do we just have more people engaged in care? Do we have more people really understanding what they have access to? I think a lot of the struggle with Medicaid can be people understanding what it means for them and what they have the ability to navigate. And I think while we all have huge hopes for care coordination, getting a call from a health plan is not always the most fun thing for anyone to experience, nor the most normal, right? We know the people in our community, we know the people we trust. So a lot of the community reinvestment funds, I enjoyed one of those questions was like, infusing back into your community, really looking at the trusted partners within your community, the people that individuals have connections to, and how can we leverage what already exists and give people a greater connection with their health care and understanding their why. There was also a great question in there about some of the stuff that we may find adjacent to Medicaid, like loneliness. One of the technology things that states have taken up on in different states around the country is member apps to address loneliness. That's a whole other pandemic on its own, right? Is really what that looks like, whether you're elderly, whether you're a youth struggling to make friends. What can we do in this space that's not a typical Medicaid traditional services to give you a connection back to your community? So I do think, I hate saying it depends, but truly in these instances, it depends. It depends on what you're targeting. It depends on how you're targeting. But I think what you always need to show is that you are actively going to be measuring what exactly is happening. Are the dollars spent? Did the communities get the money? Did we see member outcomes in the traditional sense change? And then also we know we survey members all the time on how they feel about their healthcare, and then did this impact that? And I think it's very important when you're taking this approach to investment and looking at taking their profit, right, and reinvesting it and being transparent with your communities as where to these monies went and what you saw out of it. And it doesn't mean that every time's going to be perfect. I think that's part of the journey. That's what we do in waiver demonstrations, right? We try something out and think it's going to help the overall experience of the member and really hope we get there.
Amazing.
Yeah, I'll just
Director
chime
Hookham?
in to say, so a lot of those graphics that I was showing of the expenditures are part of our evaluation process, making sure that the money is going out, identifying where the funds are going to in terms of how much is going towards housing, how much is going towards the sort of flexible, more individual focused flexible services versus the community services. So a lot of that trying to identify process measures, if speaking to a lot of academics, knowing that we've got the process measures versus the outcome measures, and that's where we really partner with some of our academic partners, and trying to get to those health outcomes are really the goal for a lot of this work, because we know that when people have those social needs met, that they are more able to see improvements in health outcomes where there are connections, and working with our academic partners, we're able to identify those places.
I think in Michigan, one more thing too is we want to see sustainability in communities for organizations that are traditionally dependent on time-limited grants for services or supports that we know are vital to improving health outcomes. So having our health plans be a part of that sustainability is really important, and then allowing the communities to determine where the priorities are and what needs to be addressed will help move us to providing that stability, and then addressing whatever priority concerns each individual community has.
Thank you. And I think that addressed some of the questions in the Q&A as well about the kind of importance of payers and, you know, how to kind of get them on board in this process too, especially when talking about the community reinvestment, where it's reinvesting their profits, as Director Flannery said. Dr. Pollack, from your perspective on kind of jumping into this research and evaluation, are there certain things that you would like to know, or ways to partner, as Director Sandeau said, on these evaluations that you think would be particularly helpful, that you didn't highlight already in your kind of wonderful overview?
Well, I think as Director Sandeau talked about, the kind of moving from process evaluation, which is so critical, to understanding the impact on outcomes and understanding, you know, that these are hopefully, by the way that these investments are designed, to be broad outcomes, that they're not designed to a particular member, but for the broader community, and understanding that often takes considerable time and investment, right? And so that working to try to create that trust to kind of build the infrastructure to allow for longer term evaluations, I think is really very essential here.
Definitely. And I think that's something that Director Hertel just hit on too, where traditionally we've kind of done this programming through grants and really kind of short-term investments, but this is an opportunity to invest kind of longer term, and maybe that's an opportunity too for that longer term kind of research and evaluation that you
And
just
so
hit
can
on.
I maybe one other point that I thought of from what Director Hertel was saying, which is that it's about the kind of the health of the community, but the health of the community can be measured at this kind of like individual level, household level, but also at the kind of the ecosystem of the service providers and the kind of the nonprofits and other community organizations that are involved in, you know, creating a healthier ecosystem for them. We hope is going to create a healthier ecosystem kind of in this in this important relationship. And so you know, I think that's another level of evaluation that I think also needs to be on the table.
That's a great point. Yeah. And I think to go back to Director Sandeau's Venn diagram, I think I really liked that slide. I think that's also a great exemplar of what everyone has hit on, of just all of these initiatives are working together, and community reinvestment initiatives are kind of just a part of all of the things that you all are doing that's groundbreaking in your states, and kind of the groundbreaking research that you're doing. Dr. Pollack.
At the fear of describing a Venn diagram in words rather than pictures, which is not what you're supposed to do with Venn diagrams, and speaking for another state that isn't here, Oregon's Venn diagram is very similar to how North Carolina sees these investments in these services, with a variety of different services being provided to all people in North Carolina, regardless of whether they are Medicaid members or not. And then a smaller circle inside of that focused on Medicaid members who are enrolled in managed care organizations that do provide these services through reinvestments and whatnot. And then an even smaller circle within that of individuals that are eligible for health-related social needs. So those types of Venn diagrams exist really in almost all Medicaid programs that have this, and really is the focus to ensure that we know that the health of our broader community does also affect the health of our Medicaid members, and so there needs to be investments in the broader community, because those folks may become Medicaid members at various points, and the goal is to ensure that we are addressing health as it is needed, rather than after it has become an issue that makes somebody unwell.
Fantastic point, definitely. And I appreciate bringing in the example of North Carolina. You know, you all are leaders, and there are other leaders throughout the country as well. And I think there's a lot of interest in this webinar and throughout the country of kind of replicating and also adjusting, right, to fit the unique circumstances of every state. And I think, as Director Flannery said too, right, within your states, right, you have a lot of different communities and different needs as well, and that's much appreciated. So looking a little bit towards the future, what do you see for the future of these programs? And based on your experiences, like, do you see that these are promising approaches to kind of population health in your states? And I saw a few questions in the chat to this. Do you have any advice for stakeholders, whether it's state policymakers, community members, providers, researchers, that are looking to pursue similar strategies in their states, assuming that you do think that they're good approaches to population health?
Yeah, I think I'll go ahead and answer this first, because this is really new to us and we're still working with our health plans to design things and implement them. And the advice that I keep giving internally and with our partners is, we don't know, let's keep trying. So, you know, it's not going to be perfect when we roll it out, and that should not be a deterrent to tell us we shouldn't keep trying. We should keep trying. And it's, I think, going to be really important that everyone stays patient and continues to broaden their stakeholder base, so that we do develop the relationships between our health plans and our communities. But I think it's going to be a little, for lack of a better word, clunky as we move forward and everyone continues to learn how this works. So hopefully the other states who are a little further ahead of Michigan, we're headed in the right way, just staying calm and seeing what happens, because I can already tell everyone wants to know what it's supposed to look like, and we're going to get it perfect. And we're just not going to get it perfect the first time around, I don't think. Probably the first 4 times around.
Well said. I think, true to New Mexico, I'm going to say you're going to ride a few horses at the same time. I think that's really important right now. Coming from a different state, I got to spend a decade in a different state where this was a normal part of the process. And so very excited to be bringing it to New Mexico. But that being said, New Mexico had value-added services for a really long time. And so just to kind of, put my money where my mouth is, we were able to evaluate the value-added services of traditional healing, bring that to CMS saying, this is what we have measured to date on utilization, et cetera. So it's just an example of you're trying things on. So we're going to try things out in the demonstration. A lot of our states are doing health-related social needs there. Looking at these community reinvestments, what can we do to kind of round out and shore out what Medicaid can do to help people in a holistic way? And then also, as the others mentioned, whether it's value added in lieu of services, et cetera, really making sure that you're taking advantage of that. I think it is, to Director Hertel's point, it's not going to be perfect. And so I think when you're not perfect, just being transparent is the best that you can do. And so saying, this is what we did, this is what we tried, these are the things that ended well for us, and this is what we'll probably replicate again. And this is what we are going to maybe not do again because it didn't show a great return on investment, but at least we spent the money we were allocated. I think the other thing that's really exciting about this is that you have this nice parking lot right now. Now, this parking lot depends on profits for community reinvestment, but I do always have, and I'm sure you all do every single day, you have a meeting you walk out of where you're scratching your head and you're thinking, well, in the traditional Medicaid sense, I don't know how to address this, but if I had a magic wand, this is what I would bring to that. And this is one of those things that you can lever to think of, okay, if I'm struggling to have individuals that are part of the Comprehensive Addiction Recovery Act, what is something, if I had some monies, I could do to really get them differently engaged in? And so, I know for us, we keep a running list of our dream projects. And so when people are submitting their community reinvestment plans, we really already have a sense of where we want to go with it. And so it's that state MCO community partnership that really guides how you do it.
I'll just agree and underline everything that my colleagues mentioned here. The only thing that I will sort of add to that point that Dana made is the connection between housing and health is so very apparent, and the need for housing is so great in our state, and having the experience of these social investment programs enabled us to be able to more appropriately and more with more information launch our 1115 health-related social needs housing benefit, which to the point that's sort of been made in the chat and by my colleagues, is something that is less focused on that remains during times of economic less prosperity amongst managed care organizations. That is one key aspect of layering in all of these different avenues and different I'm talking about three programs that accomplish a variety of different social needs in Oregon today. I would not be surprised if that continues to get added on in order to fill those gaps and be there in different times when economic or other situations arise to be able to address whatever needs are there at that time. So layering and building upon each other is so important for this work.
Greg, do you have thoughts on future direction of community reinvestment initiatives and this kind of area generally that you'd like to add to all of those wonderful insights before we move to the audience?
I was still thinking about trying to ride multiple horses at the same time. No, I think that bringing up the 1115 waiver is such an important component, and that has mandated evaluations as part of it. But kind of how do we learn from across these different waivers and kind of see what states are doing and see how the best practices can inform one another, I think is really exciting. So I'm looking forward to seeing how that plays out in the coming years.
I think that's a great sum up, right? We're all experimenting, but also trying not to reinvent the wheel and learn from each other and our own programs, right? Of what has worked, what hasn't worked, and be open-minded, I think, as you all pointed out so beautifully. With that, I'm going to turn it over to Caroline to moderate some of what's gone on in the Q&A. I know that you all already have done an amazing job of answering a lot of these really thoughtful questions. Caroline, do you want to start with some of the questions that we have in there?
Yeah, so we have a question from Ann King that asks, which of these approaches have had the least resistance from payers? And what have you done to support adoption by the payers? I don't know if anybody wants to answer that one.
I'm happy to start. I haven't had resistance, but it's a contract requirement, so they signed up. So, if you put it as part of the contract and it's part of your procurement and you're saying to play in this space, this is the this is the game we're playing. I think that's part of it. Now, looking at it from a less regulator point of view and a friendlier point of view is these are all supposed to help the humans, and that's why we're here in the first place. And so if you think about it, Medicaid does have limitations, right? So if you're thinking about it, even with some of our health-related social needs and physical health and behavioral health, there are gaps in how we look at how humans live and how they thrive. And this really does give them permission to address some of those gaps. And that's a win all around. And so I think, just working alongside them, being a partner in them with this and really looking at the end game here, which is improving humans' lives. And making sure that that is the lead of the conversation that you have. Again, I haven't experienced resistance, but it was a known contract deal.
I'll echo that. I think probably a place where you'll see more resistance conversations, just a hypothetical, it is in the space of where this work intersects with financial incentives and financial accountability of and other anything dealing with financial health and well-being of the entities that are providing the services, and so those incentives, crafting those in a collaborative way, the financial incentives, and ensuring that they are truly incentives, and something that is of importance, can ensure that you're preventing any sort of bumps in the road for the implementation process.
So there's another question about assessing impacts. So in the case where services are being delivered and documented outside of Medicaid programs, or when it's spending that's kind of at a community level, like a bike path or something, infrastructure like that, how are you, for individual level services, I guess one part of the question is, do you have ways to get access to data about who's getting those services if it's services that are outside of Medicaid services? That's the first question.
There is a good deal of reporting in this space. I think that there's always places where we could get more reporting to really do very, very comprehensive evaluation and quantitative work. So I wouldn't say, I wouldn't sort of open it up that we've got all imaginable data available on these services getting out to communities and individuals. But there is a significant amount of reporting in these programs, particularly the HRSM 1115 program, to really identify how the dollars are being used, where the dollars are being used, so that we can do some of that evaluation work.
Yeah, I think just for value-added services in lieu of services, 1115 services, we have a little bit more intrinsic tracking there. And I think it's really important as you go into the community reinvestment space, because you're going to get a myriad of proposals as to what to do with that, right? Anywhere for something that's super trackable to, I'll go with that bike path example. They would have to submit how many lives in that zone they feel will be impacted due to using bike transit, for example, but really, like, on the front end of these, how will they be measured? And so I kind of think of them as very, very mini demonstrations, right? Or how are you going to quantify the impact of this at the end of the day? And how can you tell us how many members of those that you're responsible for in this area you've impacted through this? So being very upfront and agreeing on both ends what the measurement of it will be. And then, being flexible as you move forward with any barriers.
Mm-hmm.
I have another question for what areas do you wish that researchers were focusing on that they're maybe not focusing on right now? What are some unanswered questions that would really help you in designing these programs?
I think one really hard thing, sorry, Dana, I didn't mean to cut you off, to quantify, is in many cases, some of these community organizations and recipients of the funds, by recipients, I mean the organizations that may be receiving the funds to do the work, them being able to stay in business, maintain somebody that they've hired, has sort of a non-quantifiable impact. Like we know that it is important that they maintain keeping their doors open and all the rest, but it's hard to provide numbers and justification around that, and I think that's purely by that organization not going out of business entirely is not necessarily what additional investments they can make, but them being sustained, and what impact that has on the community. So the sort of the counter being them not existing at all is often not weighed.
Dana or Elizabeth, did you want to jump in?
Or I think for me, at the end of the day, all of this is fun to evaluate and look at the data, and I am data driven, but at the same point, healthcare also is about how we're making individuals feel. And I don't want to lose sight of that. And I'm not saying there isn't research here, because I think there's research. I just think research can be improved as to how all of these things feel for the individuals on the other end of them. So if you are the individual that lived on said bike path, or if you are the individual who is in the hospital and you were struggling with addiction and your newborn baby was struggling with addiction, did that community reinvestment of me sending out all sorts of peer workers reach you? And did that feel different than a care coordinator from a health plan? I hope so. I think we're making some assumptions too when we do this, right? Like that's the best we can do, is assume that this will feel better for individuals. But I think also testing, how does that actually land with the members, and then seeking input from them in an ideal space. And I know all of us states struggle with member advisory committees and truly having the members inform our program. But I think that's really where this work would be super interesting. If we had enough leeway to say, okay, we have this amount of money to reinvest, let's check with the people that are going to benefit the most from this and see what matters the most to them. I think for all of us that have either done like health equity forums or other things to really get feedback from those we're here to serve, it's usually pretty eye-opening. And I would be lying if I told you I didn't walk away with something that I was like, oh, I didn't think of that ever before. But I'm so glad I asked the question, and I only will know if I ask the question.
That's a good segue into another. There's been several questions posed about how is it exactly the MCOs have to take into account community preferences, desires, etc., in deciding how to spend those reinvestment dollars?
Well, I'm sorry, everyone, I keep moving, but the sun came out, which was very unexpected in Michigan, especially today, because it was a blizzard this morning when I came to work, so I have to keep moving. For us, that's a great question, and the answer to that is investing in the community itself and allowing those community benefit organizations to help lead where those investments are going. And I think to Dana's point exactly, having those community benefit organizations or those community-based organizations already know what people in that community need, or where they believe that those priorities are, and then offering that guidance through the community-based organization to the MCOs.
In
How
the
about,
share program I mentioned, we have in our rules and regulations around that program, are all of our community advisory committees that are part of each of our CCOs are required to be involved in that decision making, and those community advisory committees are made up of members and other community individuals, and so that it is of paramount importance to the use of those funds.
I would just add, this to me seems like a very interesting research question about kind of how is community input kind of incorporated in the distribution of these funds, and what's the kind of variation across states? What are the best practices that states can learn from one another about kind of what's working and what are the places where it's not working? How does that align with kind of other ways that kind of other members of the community that maybe are not part of the fold, don't know to be part of the fold, would see their community needs.
Another question that's come up is what would you recommend for individuals who are interested in trying to push their state to do this kind of to include reinvestment requirements? What do you think can be the way to convince state leaders that this is a valuable thing to do?
I think it's really important to make sure that you have like state and local choice. And so that's, I always come at stuff with levers, right? We have several, I'm simultaneously doing several different levers, but, really giving the people the education of these are the different levers you have, and having it be informed that way. And so again, there's so many different ways of coming at it, at looking at just a small portion of the profit and putting that back into the community, which should benefit everyone all around. There are these other waiver ways, but really creating the options for everyone and just starting the conversation. And so I think depending on where your state's at in procurements, et cetera, is really the time to revisit that. Especially when we were looking at our new contract, we had a huge menu of levers to look at. And again, we pressed more than I thought we originally would, but it's also very nice to be able to go present to those that we answer to, both as our members and the legislature, to say, these are all the accountability measures we have that are reinvesting back into the community, that are holding people accountable for this charge of healthcare.
Any other thoughts? Elizabeth? Oh, okay. We've got some specific questions for specific plans. So there's a question about the Michigan food security programs, about whether they were offered from the medical plan, so just for members, or are they directed at a broader community?
Depends. We'll see what we get when the plans come back. Through the community-based organizations, obviously that can be through the broader community. I'd assume that we'll see the health plans doing things that are more participant focused, but we didn't really specify that. So I'll be really interested to see what sort of ideas people come back with.
Great. And were there any additional specifications in terms of the goals of the food insecurity work?
The goals are to make sure that communities get the resources that they think are important. And I think to Dana's point, we're not trying to guess. This is why we're pushing it to the community level. We need people to tell us what they need, because what they need in Detroit is very different than what they need in the Upper Peninsula. And I couldn't tell you what that is, and they need to tell us what that is. So we'll be really taking the lead from our those local partnerships.
That's great. Now, I don't know, Craig, if you know the answer to this question, or if anybody else on the panel does, but are there, with regards to evaluation, are there learnings that we can glean from the banking sector's Community Reinvestment Act? Any thoughts on that? I know nothing about it, so.
Yeah, I know just enough to be dangerous, so I'm not gonna, I think I'm not gonna try to answer that question. But
okay, do you think that there's relevance and that's worth looking into a little bit more?
Yes, potentially, absolutely,
Okay.
but I don't know enough about the research to speak well on that.
Got it. There's a number of questions around kind of data exchange infrastructure, health IT infrastructure. And folks are curious to better understand kind of, is that part of how the community investment dollars could be spent? Is that incentivized? How much of a part of your programs do you think that that might be?
I can start here. So I mentioned that the community benefit initiative as part of health related services also does include the health information technology component. And we did see on that graph that I showed earlier that has increased quite significantly over the last couple of years. And it's really meant to improve our investment in technology within our state and improve communications and coordination. So it helps to ensure that we are all of our various IT systems are really talking to one another, and we're able to identify where resources are needed and have that transfer of information occur in a seamless way. As we know, many of our community groups and community organizations throughout the state may not have sort of robust data availability and needs.
Anything either of you want to add, Dana or Elizabeth?
Just going to mention, you know, talking about that parking lot that we have for Dream Things. Sometimes in Medicaid, even in the traditional Medicaid, we set up new services and we don't have the uptake that we would want to see in those. I'll give you an example right now. We have some evidence-based practices that we added to our behavioral health benefit, and we just aren't seeing the providers, even though they get paid a higher rate for them, even though we thought we built it so they would come. I think there may be some true barriers there to how they get the training or how they take the very little staff that they have offline to go secure that training. And so this is like an excellent opportunity if you're looking at infrastructure and support that way of staff training and or support they need to even have that fiscal offset of taking on a new adventure. Because again, you know, just because you build it in Medicaid doesn't mean the providers are ready and able right away. And so I do think this is another one of those opportunities that community reinvestment can support those providers.
Makes sense. Are there any requirements that local public health departments be involved in planning or implementing community reinvestment projects? Is that something that either your states do?
Oh, I'm sorry, Dana, do you want to go ahead?
You go first.
I was going to say, our expectation is that a community-based organization has a really broad representation and that local health departments generally are a part of that.
For New Mexico, we work really closely with all of our sister state agencies. And so also thinking about getting input from them. So when we're looking to address individuals that qualify for CARA, for example, Comprehensive Addiction and Recovery Act, or when we're looking at what are we doing in our Medicaid home visiting models, any kind of look at that, we would work with our early childhood department to really collaborate on that. And then they have kind of that infrastructure into the local, the same way we do for the Medicaid equivalent, right? And so making sure that you're being collective in the process.
And our community, our coordinated care organizations work very closely with their communities, and this is part of the broader work that those organizations do to ensure that we're meeting all of the needs of the community, and really that governance approach that we have taken to the CCOs within our state does involve our local entities. And having having these particular particular funding sources as levers that the CCOs can use to ensure that we are meeting those needs is really important. So they are part of the fabric that this all fits, or the quilt that this all fits into.
Great. Well, if there are no other questions coming in, I think that we will end a few minutes early, which is, I'm sure nobody will complain about that. I want to thank so much all of you for joining us, and for our panelists and participant. Erica, thank you so much for moderating. This has been a really fabulous conversation, and I repeat that this is recorded and that we'll send out the recording to everybody. And we really appreciate all of you joining us, and we hope to see some of you at the SIREN meeting that's happening in San Diego in early February. And until then, or another webinar, we'll thank you and say goodbye.
Thank you.
Thank you all. Bye.